Okay, a very good day to everyone. Thank you for joining in and listening to my talk today. So, as you can see, I'll be talking on COVID-19 and kidney disease, friend or foe, a very interesting but challenging topic. So, just a disclaimer before I proceed. So, I'm not an expert in COVID-19. So, hopefully, by the end of this talk, you would be able to gain a little bit more knowledge, but not more confused from what I just said. The topics that I'll be covering today is little on the background of COVID-19, how acute kidney injury happens in COVID-19 patients, and how COVID-19 has affected those with chronic kidney disease, end-stage kidney disease, and kidney transplant. Okay, so in December 2019, a cluster of unknown respiratory infection originating from the Hunan, South China seafood market occurred in Wuhan City, Hubei province of China. Early January, Chinese scientists have managed to isolate this virus, which has a 96.3 similarity to the bat coronavirus and 70% homology with the SARS coronavirus, which was responsible for the SARS epidemic in Hong Kong in 2003. So this is the first electron microscope image of the coronavirus that was isolated by the Chinese scientists. And just on 12th of January, just 5 days later, WHO has declared an epidemic outbreak in China due to the then called 2019 novel coronavirus, in which now we know as the SARS coronavirus 2, and the disease named COVID-19. So on the 25th of January 2020, Malaysia has reported the first confirmed case of the COVID-19. And in March 2020, the World Health Organization Director General has declared COVID as a global pandemic. So this is a graphical illustration of the coronavirus. This is a beta coronavirus, which is a large spherical enveloped single-stranded RNA virus, and it contains four main components, which are the S protein, M protein, E protein, and the nucleocapsid RNA. And it is through this S protein that the coronavirus interacts with the host angiotensin converting enzyme 2 receptor, fuses, and enters the host cell. So how does COVID-19 transmit? So contact and droplet transmission occurs when a close contact with an infected person who sneezes, coughs, talks, or sings. Airborne transmission occurs during aerosol generating procedures such as intubation or non-invasive ventilation. Fomites happens when droplets and aerosols contaminate surfaces and objects, and this virus may remain viable for hours to days depending on the temperature. However, according to WHO, there's no specific reports on demonstrated fomite transmission. As for feces, urine, blood, intrauterine, and breastfeeding, there were no reports on transmission via these routes. Now, for symptoms of COVID-19, I think all of you should know by now, and hence I will not elaborate any further. So as of February 26, 2021, there are 112 million cases worldwide with 2.5 million mortality. Meanwhile, in Malaysia, we have close to 300,000 cases with a mortality rate of 0.38%. So let us look at the incidence of acute kidney injury in COVID-19. So in this study involving approximately 1,400 COVID-19 patients in a single center in Wuhan, the overall incidence of acute kidney injury is around 7%. However, in those with a severe disease, the incidence is as high as 41%. This study also showed that those with acute kidney injury have 5 times higher risk of mortality. So the authors of this study have concluded that although acute kidney injury was not common, but it carried an extremely high inpatient mortality rate. As for the next study, this study was done in 13 centers in New York, which involved around 5,400 patients. It showed that the overall incidence of acute kidney injury was much higher at 37%, and slightly over 1/3 of the patients who have AKI succumb to the illness. This forest plot showed a pooled incidence of acute kidney injury in almost 7,000 COVID-19 patients across several countries, namely China, Italy, United Kingdom, and United States. And it shows that there's a highly heterogeneous incidence of acute kidney injury, and in some centers up to almost 90% incidence of acute kidney injury. So what are the risk factors for acute kidney injury in COVID-19 patients? As you can see from the first study, which was done in Wuhan, the risk factors were severity of COVID disease. The more severe the COVID, the higher chance of acute kidney injury, a higher baseline serum creatinine level, elevated D-dimer levels, and also lymphopenia. As for the study which was done in New York, the authors have concluded that the risk of kidney injury were those who are elderly, those who were black, those who had comorbidities such as hypertension, cardiovascular disease, uh, diabetes, and those with a chronic kidney disease, and those who had more severe COVID-19. In this article across, which was done, a multi-center study across 67 hospitals in the United States involving about 3,000 patients, the risk factors for those who have acute kidney injury to require renal replacement therapy were those who were male, hypertension, diabetes, obesity, chronic kidney disease, and those who had severe COVID. As for this study, which was done in Iran, the risk factors for AKI were not surprisingly those with comorbidities such as cardiovascular disease, dyslipidemia, poorly controlled diabetes, chronic kidney disease with proteinuria, and those with severe COVID-19. So by now, I think if you have noticed the similarities across these multiple studies, we can conclude that the risk factors for acute kidney injury would be those with multiple comorbidities, especially kidney disease, and those with severe COVID-19. So how does COVID-19 cause acute kidney injury? Well, there are several proposed mechanisms, including the direct viral cytopathic effect, the severity of the COVID disease causing hemodynamic compromise, acute respiratory distress syndrome, direct injury to the glomerulus and also tubules, and also in certain cases rhabdomyolysis. Now, how did the patients with acute kidney injury fare? So in this study conducted by Robbins, Juarez et al., acute kidney injury was associated with 15 times increased odds of death. And in this study by Ali et al., it showed that severe acute kidney injury was associated with 4.2 times increased mortality. And up to 50% of patients did not recover to baseline creatinine levels upon discharge. As for long-term recovery, due to the paucity of data, we still do not know if what would happen to these patients with acute kidney injury. So moving on to those with a chronic kidney disease. Based on the previous slides, we would know that by now, chronic kidney disease is associated with a higher risk of a severe COVID-19 and also associated with a higher risk of in-hospital mortality. Now, as I've elucidated earlier, this coronavirus enters the host cell through the angiotensin enzyme 2 receptor, and it is a worry among early researchers that and scientists that by the usage of medications such as the ACE inhibitors and angiotensin receptor blockers, people will be more susceptible to infection and also will be more susceptible to a more severe disease of COVID-19. However, in this trial done in Brazil involving about 660 patients, it showed that in those with mild to moderate COVID-19 patients who were hospitalized, there was no difference in outcome between those who were continued or discontinued on the medications of angiotensin inhibitor, ACE inhibitor, or angiotensin receptor blocker. And in this study published in JAMA Network, which is a prospective randomized open label trial, there was no difference in outcomes between those who continued or discontinued the ACE inhibitors or angiotensin receptor blocker. So now what about those with end-stage kidney disease? The patients with end-stage kidney disease who are on peritoneal dialysis or in certain countries in which home hemodialysis is available, they are lucky in the sense that they're able to continue dialysis while self-isolating. Now, challenges occurs for those at the outpatient hemodialysis facilities in which they spend a prolonged time in the facility and they encounter similar more patients and healthcare workers at the facility, and also certain facilities with inappropriate setup. So the Center of Disease Control has then put out several recommendations on what could be done at the hemodialysis facilities, and this includes source control, in which patient, visitors, and healthcare workers of the facility are required to wear medical face masks. Screening and triage. Patients and healthcare workers are required to report symptoms or any high risk exposure, and if they do report any symptoms of high risk exposure, they should not come to the facility. And upon arrival to the facility, patients, visitors, and healthcare workers should be screened for temperature, symptoms, and exposures. As for placements of patient, they should be allocated designated treatment and waiting area which have proper distancing, and also signages should be put up so that to remind people to report on symptoms, to always practice regular hand hygiene, to wear their face masks and social distancing. As for healthcare workers, they are required to wear the recommended personal protective equipment when they are dealing with the patients who are at risk of exposure or who are positive. And facilities are required to be cleaned and disinfected regularly. And every facility should have a guideline put into place on what steps to take if a patient or healthcare worker is positive for COVID-19 or has a high risk exposure. So what about those who have kidney transplant? So I think by now you should know that should be able to guess that the kidney transplant recipients, as they are immuno compromised, they are definitely at a higher risk. So in this study, which was done in France, it showed that the kidney transplant recipients has up to 24% mortality rate, which is very much higher compared to the 1% mortality rate in those without COVID. So how has the COVID-19 affected the kidney transplant program? So generally, we see a reduced rate in a transplant, especially living donor related transplant, and hence every transplant center should have up-to-date communication regarding the operational status of their transplant programs, current practices and policies to ensure donor and recipient safety. As for pre-transplant counseling, donors and recipients should be alerted of the risks that are related to COVID-19. As for prevention strategies, the American Society of Transplant Surgeons and the Transplantation Society have their own recommendations on when to swab and how long to quarantine prior to transplant. In our local setting in UMMC, we practice a swab 2 weeks prior to transplant and also 2 days prior to transplant. And for transplant recipient, what are the challenges that lie ahead for them? Namely, three areas which are managing their immunosuppression, especially when they have contracted COVID, whether they are suitable for COVID-19 treatment and also vaccine, which needs further research on. So the take-home message from my talk is acute kidney injury is associated with a poorer short-term outcome. However, long-term recovery is not known for the time being. Usage of ACE inhibitors and ARBs in CKD patients is not associated with adverse outcomes. Hemodialysis facilities should set up a standard operating procedure related to reducing risk and management of suspected or confirmed COVID-19 patients. As for the transplant cohort, more research is needed to address the concerns that I have brought up earlier. So in conclusion, COVID-19 and kidney disease, friend or foe? I think the answer is quite obvious, and that's why we would need a new weapon to battle this, to win this war against COVID-19. And I hope those who have agreed for vaccination have already registered on my Sejatra. So thank you all for listening, and I'll be pleased to take any questions.